Good afternoon, everybody. Before I go ahead with the case, I would like to give you a little bit of background of this case. Here was a lady who had a trabeculectomy bleb, which was due to a trabeculectomy done 25 years back. And she was told that she has almost lost her vision and she will never regain her vision because the optic disc is totally damaged. And in due course of time, her cataract became more mature. And wherever she went, she was told that she cannot regain her vision. So in that case, when she came to me, she had a mature cataract, a pupil which was not responding to light because of so many synechiae which were there, a few posterior, few anterior synechiae, a bleb which was there. We don't know whether it was functional or not, but she was on 4 anti-glaucoma medication. But as a principle, over the years I have learned if there is a cataract, we should operate. Because if we leave it like that, she'll develop a painful blind eye, if not anything. So I gave her all the risk factors and told her that I'm going to go ahead if she agrees with the surgery. Even if she gets 1 line improvement, she'll be having some vision. So with that attitude in mind and her acceptance, I went ahead with the surgery and I told her that it is a very risky case. It can have, the recovery will not be complete and it may or may not give her better vision. So as you can see, as the video progresses, after I put the trypan blue, the blue portion on the top is the, there's a trabeculectomy which is stained. And here I had to choose the inferior portion for doing and AC was extremely shallow. I had to do this rhexis from the inferior side port. I knew very well that the only place available was inferiorly. I tried to make the main port temporarily, but there were so many synechiae. I tried to settle the synechiae, use high viscosity viscoelastic substance. Every time it would come out. And now I had the trouble that the iris was popping out every time. I did hydrodissection and it was difficult. I dialed the lens, started doing the phaco. Repeatedly I had to reform the AC and I started doing phacoemulsification, but again and again I had the same problem, iris, and every time I had to settle it down.
So, can you pause the video?
Yeah, sure.
What are the pressures before taking her for surgery?
Yeah, I had given her preoperatively Diamox and she was already on 3 anti-glaucoma topical medications. The pressure was well controlled, but she had, basically we could not even do an OCT RNFL because the signal strength was very less and the field was almost 0. And she was told that the prognosis is going to be not very good, but the cataract had to be operated and she agreed.
I think pre-op IV mannitol is called for in this kind of situations.
Actually, her IOP was never too much. So I did not go in for an IV mannitol because she didn't have a high pressure. It was not lens-induced glaucoma. It was a mature cataract.
Idea is not to reduce the IOP. Idea is to shrink the vitreous.
Yeah, despite that, I felt that I will pull through. And
no, the thing is, then you gave peribulbar block, no? In this case.
Pardon?
Peribulbar block.
Yeah.
So that also raises pressure. So if you give mannitol, what Arup sir is saying is, it shrinks the vitreous, then you are better off. Like this iris prolapse may have been.
So another thing that I noticed, your speculum is very widely open. Such a widely open speculum will definitely have
this was not a self-retaining speculum, it was a simple wire speculum.
Even then, so it is wide open, so much of convex is in, so much of conjunctive is in. See, when you have iris collapsing out repeatedly and you have a speculum that is widely open, so if I had been in your place, I would have changed the speculum or I would have used different kind of speculum.
Actually, she had a very small eye and I had given only 5 ml of peribulbar block. I told her, because it was a small eye, and I did not use a self-retaining speculum for this very reason, because it does increase the pressure.
Right.
And I had given pre-operatively Diamox, despite her pressures being normal.
Okay.
And I went ahead with the surgery. And
let's move ahead, yeah.
Then there was no other option but to extend the inferior side port and make it into the main port. And I did the rest of the phaco from the inferior as well as this port, wherever I could find space, and completed the surgery. So throughout the problem was the same, because it was a functional bleb and drainage was complete. So once I finished the surgery, there was no issue of increase in IOP at all. The IOP was never increased. It was just that it was a eye which was draining well, but she was not offered the surgery because of the sine K and the difficulty of the case. Somehow the surgery could be finished, and then I put a single piece hydrophobic Acrisoft IOL in the bag. However, the cortical aspiration could not be done by the bimanual irrigation aspiration cannula. It was done with a Simcoe's cannula. At one point of time, I had to ignore this little bit of iris coming out, because it was coming out and I had to finish the surgery. And the patient was told so many times by so many people that you will never regain vision, and when I gave her some hope, she was more than happy to go ahead with it. And surprisingly, you will be very happy to know her vision best corrected visual acuity now is 6/9 parts. Of course, she has got a field loss, but I managed to put the IOL in place. And I closed the wound with corneal hydration and continued with topical anti-glaucoma medication and the regular medication for after cataract surgery, the steroid antibiotic combination for about 3 to 4 weeks in tapering doses. And now she is doing extremely well. She doesn't require, she is not having any anti-glaucoma medication. She is only on tear substitutes. That's only because she says that she has some dry eye and she feels happy with it. Apart from that, she is doing extremely well. 6/9 parts is her best corrected visual acuity, and patient is extremely happy. So since it was a very difficult case and the topic said that when the going gets tough, the tough get going, I wanted to present this case here.
Yeah, Dr. Jyoti, it was a very nice case. It needs a lot of bravado to take up a case like that. See, another thing is when the iris was prolapsing out, maybe one could have used an iris hook to, push it out, to keep it out of harm's way. And then after that, there's no question of an iris prolapse. All the instruments will go in very smoothly. An iris hook perhaps could have made it a little easier for you.
Sir, the iris was actually very thinned out, and there was anterior synecia which I had broken. In the first few steps
so
only,
it was floppy.
Yeah, so it was very floppy. Nothing would have stayed.
No, what he's saying is right, that once you pull it with iris hooks, maybe not, if one, maybe two, it stays there. Nothing.
Okay,
so like
but then
these are just things which we can always use, and we keep in mind in next case. It was really wonderful and courageous of you to do this.
Yeah,
You know,
and I'm happy, and she has recovered extremely well after that.
Yeah, of course.
Yeah,
of course.
Thank you.
Hard work always pays.
May not pay, though throughout I kept telling her that you may or may not get vision, and now she's so happy that she's off all medication, and she's extremely, extremely happy, because for 25 years she believed that she'll get no vision, and now she's got vision.
So you use 2.2 millimeter incision, no?
Yes, yes.
Yeah. So I do all my phaco with 1.8. So even if I have to make one extra port, it's very small, 1.8, no? So many times in post-apolar cataract also I use dual site. If you don't want to rotate nucleus.
And what's amazing here is like 270-degree anterior synechial was there. There was no place to go in except for inferiorly. There was no other place. At least 3 times I had to shift during the surgery only to enter from somewhere or the other. So it was a difficult case.
Thank you.
Thank you.
Another thing is, see, you really don't have to do a peripheral anti-synucleus most of the time. You know, if iris is adherent to the cornea and the periphery, you can go through straight through the iris, because iris and cornea, they're one unit. You can make the tunnel and enter through the iris. So now once you do separate the synechia, iris becomes much more floppy. Particularly, this must have been an angle closure glaucoma patient, you know, and then the floppiness could have been reduced if we had not done the peripheral anti-synucleus.
I was fearsome of some bleed or hyphema, getting into more trouble. So that was my take at that point of time.
Ma'am, what was the AC depth? Was it very, very shallow in the beginning?
Yeah, while I was doing surgery, it was again and again.
No, pre-operatively was it?
Pre-operatively, it was shallow, not very shallow. It was a draining bleb actually. It was a draining bleb.
Because most of these cases obviously have a very
in
mobile
fact, like
iris
AC
lens
depth
diaphragm.
is, like angle of the AC is measured between the iris and the cornea. That is what is defined. So much of synechia was there. In the traditional way, we couldn't have even measured the angle of the AC as such. And you know, the synechia per se prevented us to do anything apart from that. Even I tried doing ASOCT and find out something. It was not, I was not able to find out.
Thank you very much.
Thank you so much.
Thank you.